sir.
Good morning, everyone. On behalf of Adelaide Oncology, I would like to welcome the speaker of today's webinar, Dr. Sonia Nityanand, Chief Guest, Dr. Alok Srivastava, discussants, Dr. Sandeep Shah, Dr. Dinesh Bhurani, Dr. Sharad Damodar, Dr. Sanjeevan Sharma, Dr. Ashish Dikshit, Dr. Samir Meliankeri, Dr. Anupam Chakrapani, Dr. Srinath Shirsagar, Dr. Ruchira Mishra, Dr. Rashmi Palaseri, and Dr. Shilpa Prabhu. Before we commence the event, I would like to present you a small corporate video. Roshni, can you please run the video, please? Thank you, Roshni. Now to commence the event, I would like to hand over the stage to teacher of teachers, the most respected, our very own Professor Dr. M.B. Agarwal, sir, please. Thank you so very much.
Thank you, Mr. Ashutosh. So, good morning to one and all. Today, we have a webinar on allogenic hematopoietic stem cell transplant in aplastic anemia, strategies and challenges. The speaker is Professor Sonia Nityanand from Lucknow. This webinar is brought to you by Mumbai Hematology Group, supported by Adelaide and managed by Mice Ideas. Just to introduce you to the next weekend activities, Saturday, 26th March, 7 p.m. Dr. Maury Gertz from Mayo Clinic, Rochester, Minnesota, US, will speak to us on role of stem cell transplant in multiple myeloma. And next Sunday morning at 11:30 a.m., Dr. Lena Speck from Denmark will speak to us on total body irradiation in hematopoietic stem cell transplantation, current status and future directions. I thank Mr. Ashutosh Shukla and the team from Adelaide for supporting our academic activities, Mr. Rajesh Kalpesh and the team Mice Ideas for managing the webinars, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Professor Alok Srivastava from CMC Vellore, our guest speaker, Professor Sonia Nityanand from Lucknow, all our discussants who are themselves very eminent hematologists or bone marrow transplant physicians, new participants from 14 to 15 countries for sparing your Sunday morning. It's time to introduce our chief guest of the day. He doesn't require an introduction. He's a towering personality in the field of hematology, stem cell therapy, gene therapies, and so on. Dr. Alok Srivastava, MD, FRACP, FRCPA, FRCP from CMC Vellore. He's professor in the Department of Hematology and head Center for Stem Cell Research at Christian Medical College, Vellore. An alumnus of CMC Vellore, he has helped build the comprehensive adult and pediatric hematology services and teaching programs at this institution over the last 3 decades. He's a founder teacher for the DM Hematology program in India. His research interests have been in hematopoietic stem cell transplantation and hemostatic disorders. He has over 350 scientific publications to his name. Over the last 12 years, he has been responsible for establishing the Center for Stem Cell Research, Velo, as a translation unit of the Institute of Stem Cell Science and Regenerative Medicine, Bangalore, as a collaboration between this institution and CMC Velo with the Department of Biotechnology, Government of India. The major focus of current research of his group is the development of gene therapy for hereditary hemorrhagic disorders with several international collaborations. He's also working with several colleagues in different departments of CMC Velo to establish the first large comprehensive control program for the major hemoglobin disorders in India, supported by the Department of Biotechnology, Government of India, in the collaboration, the state government in Odisha. It's my wonderful pleasure to have him as the chief guest for the day. He'll inaugurate our today's webinar and give us some words of wisdom. Over to Professor.
Thank you, Dr. Agarwal, and good morning, everybody. I'd like to thank the Mumbai Hematology Group for this invitation. Chief guest roles are not exactly what I'm comfortable with, but when I was told that my brief was to say something about hematology and hematologists in India for 3 minutes, I thought I'll give that a try. It is widely recognized that there is gross inadequacy of well-organized hematology services in the country. On a macro scale, there are many tier 1 cities in India with none or just 1 or 2 qualified hematologists. Their availability in the tier 2 cities is a rarity. There are perhaps less than 1,000 formally trained and certified hematologists in the country of more than 1.3 billion people. This number is around 10,000 in USA with less than 1/4 of the population. And in Brazil, with less than 1/6 of our population, there are more than 2,500 hematologists. I do not know how many people know that the third largest hematology meeting in the world after ASH and EHA is most probably the Brazilian meeting with more than 4,000 participants. So why is it like this? I think there are several reasons. Inadequate number of formal training programs, increasing very slowly over the last 22 years since it was first initiated, and lack of suitably equipped and staffed infrastructure for hematology in both the public and private sectors are, I think, the predominant reasons. Challenges at both ends of the numbers trained and the job opportunities, ignoring the huge human need for these services in our country. Unfortunately, hematology does not lend itself to solo or near solo practice and as some other specialties, and needs a team with a strong support structure for transfusion and other services, including good radiology and laboratories, as well as consultation from other specialties. It also therefore comes down to a lack of awareness of the need and scope of this specialty among health planners that this situation exists in our country. But it is such a beautiful subject, so wonderfully integrating diagnostic and therapeutic aspects, applying the latest technologies in molecular and cell biology in nearly all aspects of management, and where there is so much scope for highly gratifying services for diseases where therapy brings about tremendous relief and cure in dramatic ways. Stem cell transplantation as a major curative option for so many malignancies, marrow failure, and genetic disorders is an example of how change is brought about. And in fact, in the space of gene therapy, early products are all in the hematology space. I'm very glad to let you know that we have obtained all required approvals for the first gene therapy clinical trial in India with the first in human protocol for hemophilia A, which will be starting very soon. Programs like this webinar and many more organized by Mumbai Hematology Group and other agencies are a great source of exposure to the scope of this subject. And today's speaker, Professor Sonia Nityanand, is herself a wonderful example of a physician scientist who has not only established a comprehensive service in a major hospital, but has also set up research and teaching as an example of what is possible to achieve in hematology. So I hope that such examples will help enhance this subject from all aspects, service, education, and research, because there is just so much to be done. Let me stop there and wish everyone a wonderful time at the program today. Thank you, Dr. Agarwal.
Thank you, Professor Alok, for those words of wisdom and passing on the message to the youngsters who are listening to you today in large numbers. You spared your valuable time and blessed us. I'm grateful to you. With this, we'll move on to the second part of this morning, and that is our Sunday quiz. So today, we will show you a picture. There's a question mark, and you have to guess what is the answer at that question mark. And you have to send your answer by email to mbagarwal1@gmail.com. And as usual, the fastest finger first will be the winner. And of course, we will read out names of all those whose answers are correct. So now we will show you the picture. You study the picture, you look at the question mark and see what should have been there at that question mark. We'll keep the picture on for 20 seconds. So that's the question mark. That's the picture. And you forward your answer to mbagarwal1@gmail.com. Winner will be the fastest finger first. And after Professor Sonia's lecture, before we go to the Q&A session, we'll give you the correct answer as well as who has won the prize and who are the correct answers. The next part this morning is to discuss the weekly case profile. So this is the case profile for this week. A 45-year-old man, an employee in Italian embassy in India, having beta thalassemia intermedia, also known as NTDT, was seen for a hemoglobin of 7.5 or round about that. Until the age of 45, he has been transfusion free. However, he has now developed significant exertional breathlessness. His workup showed that he has pulmonary hypertension, congestive heart failure, and paroxysmal atrial fibrillation. Besides other drugs, the cardiologist put him on oral anticoagulants and requested us to improve his hemoglobin with an idea of at least 9 grams. That means he wanted the lowest hemoglobin to remain at 9+. We failed because any attempt to give him Paxil led to worsening of his cardiac failure, and no effective Paxil transfusion, despite diuretics, etc., could be done to him. He was unable to tolerate the transfused volume, as that was triggering an acute worsening of his pulmonary pressures and exacerbating the cardiac failure. He was then started on a medical therapy, which acted like a miracle for him. Many of you might have guessed which this drug may be. This is not a quiz, so don't have to answer. And what he was put on was luspatercept. By now, the word is very familiar in the hematology community all over the world, because this drug, under the name Reblozyl, has already been licensed in US and Europe for almost about 3 years now. Available in 2 strengths, 25 milligram and 75 milligram, through BMS. And those are the 2 vial strengths, 25 milligram and 75 milligram. It is given subcutaneously once in 3 weeks. We must appreciate the efforts of Dr. Maria Capellini from Italy and Dr. Ali Tahir from Lebanon, as a result of which multicentric trials were conducted all over the world and ultimately led to not only FDA but European approval of Reblozyl, luspatercept AAMT, for the treatment of adults with beta thalassemia, transfusion dependent, and also at the moment non-transfusion dependent. Of course, it is also approved for low-risk MDS needing blood transfusion where EPO has failed, but that's not the subject for discussion today. What it does is it reduces the blood requirement. We have erythropoietin, which works early in the erythropoiesis. And now we have luspatercept, which acts late in the erythropoiesis. What it does, it reduces the ineffective erythropoiesis and promotes the erythroid maturation in beta thalassemia, in MDS, and in myelofibrosis. It does that by reducing the excess of GDFs, which results into inhibition of activation of SMAD2, SMAD3, SMAD4 pathways, and thus restoring the functional gene expression, which allows maturation of the erythroid precursors. And that's what is shown to you in this cartoon, that this is luspatercept, that is transforming growth factor beta family ligand, and by entrapping that, it inhibits SMAD2/3, and that results into activation of the maturation of the erythroid precursors. As a result of this, it reduces the transfusion burden in both TDT and anti-DT, and this could be of various extent. It improves the hemoglobin, again, both in anti-DT and TDT, as you see over here. And because you require less transfusions, it results into reduced iron burden. And interestingly, it also interferes with the gut absorption of iron, because ineffective erythropoiesis allows more iron to be absorbed from the gut. So when ineffective erythropoiesis is curtailed and converted into effective erythropoiesis, less iron is absorbed. So it improves the hemoglobin, it decreases the transfusion requirement, it decreases the iron overload. So that's fantastic, because this is first major breakthrough in the treatment of both NTD and non-transfusion dependent anemia in thalassemia. An interesting case has been published where a non-healing ankle ulcer in a thalassemia intermedia for the first time healed up by giving luspatercept, because it improved hemoglobin, decreased hypoxia in a long fashion. There are two major trials, BELIEVE and BEYOND. BELIEVE is for transfusion-dependent thalassemia, and BEYOND is for non-transfusion-dependent thalassemia. And these are the publication, Ali Tahir and Capellini, luspatercept for beta thalassemia, beyond red cell transfusions, published last year, 2021. And that's another one in Blood Advances, the use of luspatercept in thalassemia in adults, again by Capellini and Tahir. To conclude, luspatercept is a novel erythroid maturation agent, which has been now approved both in US and Europe for the treatment of anemia in adults and above the age of 18 years with beta thalassemia who require regular transfusion support. Phase 3 results indicate that substantial reduction in transfusion burden may be achieved in patients with both beta-0 and non-beta-0 genotypes. Luspatercept is well tolerated. The most common adverse events are skeletal-muscular pain, 3% incidence of thromboembolism, and 5% incidence of hypertension. Overall, these are infrequent and extremely manageable. Randomized double-blind phase 3 trials in adults of beta thalassemia, TDT, BELIEVE, and anti-DT BEYOND. These were trials where best supportive care plus luspatercept was compared with placebo for almost about a year. It's an easy drug to administer, 1 milligram per kg subcutaneously once in 3 weeks. And you can go up to the dose of 1.25 milligram per kg subcutaneously once in 3 weeks. There are studies to show that it improves the health-related quality of life, reduces the transfusion requirement, improves the hemoglobin, and decreases the iron overload. Our patient, courtesy Italian embassy, was put on luspatercept 50 microgram, which was equivalent to 1 milligram per kg for him, subcutaneously once in 3 weeks. His hemoglobin increased to 10.1 G per DL within a month, and gradually his nether hemoglobin was maintained above 9.2 G per DL. He's remained transfusion-free. Remember, he has never received transfusion in his life, and is now able to perform his duties without feeling breathless. This case is relevant to us because BMS is going to market luspatercept. It has already got the drug controller's clearance and is going to market this compound in India in next 3 to 4 months, both for both the types of thalassemia and MDS. And there's going to be PAP, so we will be able to afford it for good number of patients. The clearance is only for adults above the age of 18 who are either transfusion-dependent thalassemia or non-transfusion dependent. And now the most important part of the day, the guest lecture on allogenic hematopoietic stem cell transplantation in aplastic anemia, strategies and challenges. Our discussions today are a galaxy of hematologists and transplanters from India. We have Dr. Sandeep Shah from Vedanta, Ahmedabad, Dr. Dinesh Burani from Rajiv Gandhi, New Delhi, Dr. Sharad Damodar from Majumdar Shah Medical Center, Bangalore, Colonel Dr. Sanjeevan Sharma from Command Hospital, Lucknow, Dr. Ashish Dikshit from Manipal Hospital, Bangalore, Dr. Samir Malinkari from Dinanath Mangeshikar, Pune, Dr. Anupama Sharma from Fortis Hospital, Noida, UP, Dr. Srinath Kshirsagar from Global Hospital, Somaya Medical College, Mumbai, Dr. Ruchira Misra from SRCC Children's Hospital, managed by Narayana Hridayalaya, Mumbai, Dr. Rasmi Palasari from Ramaya Medical College, Bangalore, and HCG MSR Cancer Center, Bangalore. Dr. Shilpa Prabhu from Majumdar, Bangalore. And now it's my privilege to introduce our guest speaker for the day. She has been our regular faculty, both in person and online, for decades. And thank you so much, Professor Sonia Nityanand, for taking all this trouble for educating the community in India and many countries around through these webinars. She's MD, PhD, FNA Science, FA Science. She's Director, Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Former Executive Registrar, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Former Professor and Head Department of Hematology and Stem Cell Research Center, SGPGI, Lucknow. She did her MD Medicine from King George Medical College, Lucknow, followed by PhD in Medicine from Karolinska Institute, Stockholm, Sweden. She is Nodal Officer for Hemophilia Program for the state of UP. In 1999, she established the bone marrow transplant program as SGPGI. In 2003, she established the first department of hematology in SGPGI. In 2018, she established the world-class stem cell research center at SGPGI. She initiated DM in clinical hematology, postdoctoral certificate courses in hemato-oncology, pediatric hematology and hematopathology, and postdoctoral fellowship program in BMT in SGPGI. She is fellow of 2 of the 3 national science academies, the National Academy of Sciences, India, and Indian Academy of Sciences. She has over 125 research publications in peer-reviewed international and national journals. During her career at SGPGI, she successfully raised research funding of over 13 crores for 24 projects. Well, we invite her to deliver her lecture.
Professor M.D. Agarwal and all the members of the Mumbai Hematology Group, Professor Alok Shrivastava, who is the chief guest for this function, all the esteemed discussants, and all the participants who have joined through the video conferencing on the video conferencing platform, Mr. Ashutosh Shukla, and all the members of MICE Ideas. A very good morning to all of you. And at the outset, I would like to thank Dr. M.B. Agarwal for inviting me to deliver this educative talk today for all the residents and postgraduate students of hematology. Thank you for the kind introduction also, Dr. M.B. Agarwal. And I think it's a wonderful beginning to our webinar today to have Dr. Alok Shrivastava declaring that the first gene therapy of the country he's received the permission to start the first gene therapy of the country. It's a very proud moment for all of us in India, And I would like to congratulate you, Dr. Alok, for this effort and perseverance of yours. Today we have very eminent, as Dr. Agarwal already highlighted, we have very eminent bone marrow transplanters who are participants in this webinar. And I would request Dr. M.B. Agarwal to slightly change the way the webinar is conducted. Normally, the discussants at the end of the talk ask questions. I would also like them to answer some of the questions because they have extensive experience in bone marrow transplantation as a whole, and especially in bone marrow transplantation for aplastic anemia. So they may also want, because a lot of students are going to be have joined in this webinar. So I would request all of you to very actively also join in answering the questions and sharing your experience. So with this, I would like to thank you all for joining in, and I would like to begin my talk today on allogenic bone marrow transplantation. So I'll begin by sharing the screen. Okay, is my screen visible?
Yes.
Okay, so I'll start today.
And show mode.
It's on the show mode. I
No.
hope it's
No.
Is it now okay?
Ma'am, please stop share and share it again.
Okay, all right. I'll do it again. Is it showing now, Roshni?
No.
No, ma'am, we can't see your slides.
Okay, all right. I'll just log. I will do it again. Is it visible?
Slideshow mode.
I am in the slideshow mode. I don't know why it's not taking it.
You have your presentation with Roshni?
No, sir.
Okay. Try again.
Okay.
Yes.
Is
Perfect.
it now okay?
Perfect.
All right. Okay. Sorry for the delay, and I'll start now. So I just wanted to tell in the beginning that there has been a sea change in the treatment with improved survival in aplastic anemia. If you see in 60s, what we had to offer were androgens and supportive care. In 70s, we had ATG, which led to a survival of about 30 to 60%. In 80s, cyclosporin was added to the ATG platform with a further increase in the survival to 60 to 75%. And lastly, we have optimized the hematopoietic stem cell transplant protocols. The ATG reduces the graft rejection in the graft versus host disease, and there are improvements in supportive care. So our survival rates are as high as 85 to 90%. But on the background, it is important to remember that there is a significant issue in aplastic anemia, which is clonal evolution. I'm going to be focusing on acquired idiopathic aplastic anemia. So we all know as of today that it's an immune-mediated disease, perhaps in the face of a viral infection in a susceptible host, like for any other autoimmune disease. The autoimmunity is triggered off to the human stem cell progenitor cells with a oligoclonal expansion of the cytotoxic T lymphocytes, which lead to the secretion of anti-hematopoietic cytokines like TNF alpha, interferon gamma, in the background of intrinsic defects of the hematopoietic stem cell progenitor cells, like a decreased telomere length, leading to these cytokines lead to an increased apoptosis of the HS species. And when we give immune suppression in the form of ATG cyclosporin, it will lead to a selection of clones which have unfavorable mutations like DNMT3A, ASXL, and immune escape of clones like 6P, UPD, and PIGA mutations, which is responsible for the clonal hematopoiesis, which is seen after immunosuppressive therapy. So this is just an overview. And I wanted to touch on it because it has a huge bearing even on the transplant in aplastic anemia. So what is the Indian perspective is that the incidence of aplastic anemia will vary from 1.4 to 14 cases per million population and is higher in Asia than in the West. And the reason one doesn't really know, but it is attributed to a lower socioeconomic status and a higher exposure to environmental toxins and pathogens. In India, there is no systematic national study describing the incidence of aplastic anemia. Though a prior study in the pediatric population predicted the incidence of aplastic anemia to be around 6.8 per million in the Lucknow region. This is a publication way back in 2006. So what is the treatment algorithm broadly? A lot of it will be individualized, but what is broadly the treatment algorithm and in acquired idiopathic severe aplastic anemia? As I said, majority of which are the immune-mediated cases. The whole treatment algorithm is dependent on whether an HLA-matched sibling is available. If available, and a patient is less than 40 years of age, the first option is a sibling-matched transplantation. However, in those who do not have an HLA-matched sibling, what does one do then? This is an evolving area where in patients less than 20 years, in the absence of an HLA-matched sibling donor, upfront is coming an unrelated AMUD transplant. So this is the area which is coming up. In all others, in the absence of an HLA-matched sibling, the choice would be to go through immunosuppressive therapy, which if it fails, then one thinks of an alternate donor transplant. Except in those who are above 60 years of age, where even if immunosuppressive therapy fails, you may not consider a transplant in most cases. And one thinks of other therapies and clinical trials. This whole age of 40 years is not a magic age. In a lot of centers, in the presence of an HLA-matched sibling donor, a transplant may be even done up to 50 or 55 years of age. A lot of it depends upon many other factors like the status of the recipient and how well the patient is, how severe is the disease, because there are several advantages of doing transplants over immunosuppressive therapy. I'll come to that. So, and in India, these algorithms, of course, are also dependent that patients who fail on immunosuppressive therapy may not have enough finances and may not reach the stage of the transplant. So maybe a lot of centers will not use a cutoff of 40 years. They may even go up to 50, 55 years of age if there is an HLA matched sibling donor present. So that's one area which I wanted to highlight. And second, in less than 20 years of age, a mud transplant is a very good option to immunosuppressive therapy in the absence of an HLA matched donor. So what are the factors which needs, as I said, to be considered while selecting an upfront therapy? The age, the comorbidities, the disease severity. For example, patients with very severe aplastic anemia or severe aplastic anemia are less likely to respond to immunosuppressive therapy. And they have the propensity for fatal complications such as infection and recurrent bleeding. And clonal evolution. Patients with one or more prognostic mutations, splicing factor genes, CBL genes, SETBP1 gene, have a very high incidence of evolution to MDS AML in the subsequent years, 7 to 8 years post-transplant. And that may be a driving decision for the first-line upfront therapy towards transplant rather than towards an immunosuppressive therapy. So all these are factors which will, make you bend the age factor for a transplant, or vice versa. If there is a patient with a lot of comorbidities, even if he is young, with a matched sibling donor, sometimes you don't think of a transplant upfront. So why this cutoff age of 40 years? This is the earliest EBMT data of matched sibling donor transplants in severe aplastic anemia, published by Basigalapo in Blood. And if you see in patients with ages 1 to 20 years and 21 to 40 years, that is less than 40 years, the survival curves are 86% and 76%, and a steep drop to 55% in those aged more than 40 years. And that's why the choice of a matched related donor transplant in those less than 40 years as the upfront treatment. The EBMT registry shows certain negative predictors of survival after transplant in aplastic anemia. They say a peripheral blood stem cell source. I'll touch upon this later. The interval from diagnosis to transplant, if it is prolonged, an age which is more than 20 years, no ATG in conditioning. If there is a CMV donor recipient status other than negative, red blood transfusions more than 20, platelet transfusions are more than 50, and a previous Hsct. So these, according to the EBMT registry analysis, are negative predictors of survival. So let's start with the matched sibling donor transplant. As I said, with the availability, there is an available matched sibling donor. The first-line therapy in patients less than 40 years of age will be a matched sibling donor transplant. And different studies have shown a survival, disease-free survival of 60 to 90%. And factors which affect survival at older age, this is very important, the interval between diagnosis and the transplant, the number of transplants before the number of transfusions before the transplant, and the GVHD prophylaxis. In India, some of these factors are very important, especially the long delay between diagnosis and transplant and the multiple transfusions that patients have before the transplant. Because they take time to arrange finances, they take time to arrange voluntary donors for blood and platelets. I'll be coming to the conditioning regimen and to the graft source in my subsequent slides. So this is where history starts. And if you see the Christian Medical College, CMC, the law data, world over, the standard conditioning regimen was a combination of cyclophosphamide and ALG. And if you see, this is a very early publication of 2007, and all of us have actually been guided by this publication in deciding our conditioning regimen. And if I want you to focus on this, using Psi-ALG, the rejection rates were as high as 30%. And hence, the overall survival was only 46%, and event-free survival was only 38%. I still remember when I did my first ATG, I did my first aplastic transplant, the patient rejected. And it so happened that I met Dr. Maman Chandi in a meeting in Delhi. And I almost cried to him. I said, my first aplastic is rejected. And then he shared with me, he said, don't worry. The rejection with Psi-ALG, ATG is as high as 30%. And he said, we have moved now to using a fludarabine-based conditioning regimen. That at that time, it was fludarabine, busulfan, cyclophosphamide, and ATG. And later it became fludarabine, cyclophosphamide, and ATG. And if you see the same CMC Vellore data from a rejection of 30%, went down to a rejection of only 3%. And the overall survival from 46% increased to 82%, and an event-free survival of 38% to again 82%. And there was a dramatic change in the recovery of the ANC also, a significant change from 16.8 days to 12.3 days, and in the platelet recovery also. And the reason is that in India, our patients come in very late, they are multiply transfused, heavily immunized, and therefore we need an intensively immunosuppressive therapy rather than an ablative therapy for the success in the transplant of aplastic anemia. So from here, there is the subsequent publication from, again, CMC Vellore, from Biju George and the group of CMC Vellore, which has recently got published in 2021. And there they have tried to look at whether they can do away with ATG, just use fludarabine and cyclophosphamide in the match-related donor transplants for aplastic anemia. So instead of a combination of fludarabine, cyclophosphamide, and ATG, they have used fludarabine and cyclophosphamide. And the stem cell dose has been the PBSCs, the peripheral blood stem cells, where at least 6 to 8 million cells per kilogram, CD34 positive cells per kilogram were infused. And the prophylaxis for GVHD was cyclosporin methotrexate, which was 10 in 2013, starting with a methotrexate dose of 10 milligrams and increased by 10 milligrams per square meter surface from day 3, 6, and 11, and subsequently to 15. And a few patients in this publication have also been put on post-transplant cyclophosphamide mimicking the haplotransplant GVHD prophylaxis for 2 days. And in those who were given PTCI, 1 single dose of total body radiation of 200 centigrade on day -1. And the reason why they have adopted this, why they have investigated in this protocol is because in India, you have huge financial constraints where ATG is a good chunk of the total financial burden of the transplant, almost 30%. And therefore, if one can do away with ATG, it will save a lot of finances for patients. And number 2, you're not spending another 3 to 4 days of giving ATG, and you can push in the graft much faster. So with this, the CMC, this is their transplant, the baseline patient characteristics. And as you can see, that the time from diagnosis to the transplant, which I was trying to highlight, is quite high, 4 months. And the median number of transfusions before the transplant is 18, with a range of 2 to 160. And you know, it's a total cohort of 212 patients. And the active infections at the time of transplant is 18, which is 8.4%. And patients who had fever and hospitalization in the preceding 4 weeks is 56, which is very high, 26.4%. And a good chunk of the patients, if you see, 65% are in the high-risk group. So what is a high-risk group? Is where the time from diagnosis to the transplant is more than 90 days, 3 months, more than 20 transfusions before the transplant, a previous exposure to ATG, and an active infection, bacterial or fungal, or an ongoing culture negative sepsis at the time of the transplant. Any one of these. And absence of any one of these would push them into the low risk group. So obviously, majority of our patients will be in this high risk group. And what the data shows here, if you see the overall survival of the entire cohort, irrespective of low risk, high risk, age, is 75.3%, which is at a median follow-up of 46 months, which is actually excellent. And obviously, there is less than 20 years, 20 to 40 years, and more than 40 years. These are the overall survival curves without any statistical difference. But there is a statistical difference between the low risk, where the survival is as high as 93%, vis-a-vis a high risk, which is 65.7%. So what is the conclusion? And I just wanted to touch also the graft versus host disease in the cohort, in this cohort of patients, is acute graft versus host disease is 27.9% and chronic was 41.6%. So the factors which influence the overall survival were the age of the patient, diagnosis of very severe aplastic anemia, the donor age, presence of fever in the 4 weeks prior to the transplant, time to platelet recovery, presence of acute GVHD, graft failure, high-risk status. But what actually showed up in the multivariate analysis was only acute graft versus host disease and graft failure was significant. So one can conclude that an ATG-free conditioning protocol of flu-cy has an overall survival of 75%, and the best it does is in the low-risk patients who had an excellent overall survival of 90%. So this is some of the data from the Indian stem cell registry, stem cell transplant registry, which has been presented by the CMC Vellore group and published in Blood 2015 as an abstract. And it's a mixed bean of patients where they've used, the patients have been given Cy ATG or Cy TBI, but majority have been given a flu Cy without ATG protocol. And in most, the peripheral blood stem cells have been the graft source. And the graft failure is down to about 3%, acute graft versus host disease of grade 2 to 4 of 29.3%, and grade 3 to grade 4 of 14%, and chronic GVHD to 41%. And a 5-year overall survival of 66%, and being better in children versus the adults. And where a fludarabine-based regimen was used, it was almost 70%. And again, better with the PBSCs. So this is some of our data. We have an experience of 41 patients with a mean age of 20 years, median age of 20 years. And in most of our patients, we've used a combination of fludarabine, cyclophosphamide, and ATG. We've had no graft failures, and our total deaths have been 29.3%, where 19.5% were due to infections, 1 due to hyperacute GVHD. And what is interesting is we have a thrombotic microangiopathy in 2 patients. It seems, and it's reported in literature also, that TMAs are much higher in aplastic transplants. We've actually had TMA in 3 patients, out of which 2 have died, and a refractory CMV in 1 patient. So our 5-year overall survival is 70.7%. So if you see the EBMT data, it will suggest the use of bone marrow being advantageous in all groups. If you see, it's better for grade 2 for GVHD, grade 3 for GVHD, chronic GVHD, and extensive GVHD. So the Europeans will always, the Western people, advocate the bone marrow as a source of the graft, whereas most of the Indian data is with peripheral blood stem cells. And the reason, again, I said, is our patients are heavily infected, heavily transfused, and with peripheral blood stem cells, the engraftment is much earlier, and therefore it has a huge advantage. So coming to this is a very interesting study which was undertaken by Dr. Rajat Kumar and published in 2016, where he looked at the graft source for the matched sibling transplants across different economic regions of the world. You have the high economic regions, USA, Canada, 402 patients. Other high economic regions, 1,268 other than US and Canada. And then the upper middle economic regions, which is 482, and then the lower middle and lower economic countries, LM and LIC, which is 146, in which India comes, the lower middle and lower economic countries. And the data is quite interesting. When one looks at the overall survival, where bone marrow is the graft source and PBSC is the graft source. In US, Canada, there is a significant difference in the survival, overall survival, with bone marrow having a better overall survival. So there's a significant difference than PBS. But in the lower middle and lower income countries, which includes India, there is no survival advantage. On the other hand, in the lower middle income countries and lower income countries, there is a huge advantage for neutrophil, 28-day and 100-day neutrophil engraftment, favoring the much higher in the PBSC group, significantly higher. And however, it is to be mentioned that the chronic GVHD in both US, Canada, and the lower middle and lower income groups is significantly higher in the bone marrow group in comparison to the PBSC. But it does not obviously have an impact on the survival in the lower middle and lower income countries like India. So the conclusions are that in patients less than 40 years, as I said, with the availability of a matched sibling donor, the choice is a matched sibling donor, hematopoietic stem cell transplantation. The conditioning would be fludarabine, cyclophosphamide with or without ATG. Especially ATG can be done away with in the low-risk patients, which I showed you by Dr. Biju George's data. And the standard graft versus host disease prophylaxis is methotrexate and cyclosporin. And in India, the advocated stem cell source would be peripheral blood. But there is always a need for betterment, and the area for betterment would be a more profound GVHD prophylaxis. So from here, I move on to what is matched unrelated donor transplant in aplastic anemia. And if you see, this is a very hallmark study published by the EBMT, the UK Pediatric Bone Marrow Transplant Working Party, Pediatric Diseases Working Party for severe aplastic anemia Working Party of the EBMT. And what they found is that there are comparable overall survivals between upfront MUDs and a matched sibling donor transplant. Means if there is absence of a matched sibling donor and one does a MUD, the overall survivals and the event-free survival are comparable. Further, they also found that if you compare a MUD transplant with standard immunosuppressive therapy, the overall survival is comparable. And with a MUD transplant, if you do it upfront, in comparison to a patient first going through immunosuppressive therapy, failing, and then you do a MUD transplant, the overall survival is much better if you do it upfront rather than doing it post IST failure. And almost the same kind of data for event-free survival. Obviously, with the MUD transplant, it is much superior than immunosuppressive therapy, and it is superior if done upfront than after the failure of IST therapy. So this has led to an amendment, a pediatric amendment to the British guidelines, British Society of Hematology guidelines for aplastic anemia. So MSD, Hsct, the matched sibling donor transplant should be the first line therapy in children with idiopathic severe aplastic anemia. However, in the absence of a matched sibling donor, IST with horse, ATG, and cyclosporin are considered as first line. But now the unrelated donor Hsct, if readily available, should also be considered as it has slipped to the first line. This is the amendment in the absence of a matched sibling donor. And this decision, whether it should be a matched unrelated donor or IST in the absence of a matched sibling donor, should be taken within 6 weeks of the diagnosis. And a MUD transplant should be performed no later than 3 months after the diagnosis. And what are the factors which will actually push towards a MUD transplant over an IST, immunosuppressive therapy, in patients less than 20 years will be the rapid availability of a donor. If the patient has recurrent life-threatening infections, because IST takes at least 3-4 months before it produces a response, and patient will succumb in this period to life-threatening infections. If there is a cytogenetically abnormal clone, which is suggestive of MDS, the donor is not a multiparous female and the donor is less than 45 years of age. This will give you a this will actually favor an upfront mud over an immunosuppressive therapy in patients less than 20 years of age who do not have a matched sibling donor. So what are the conditioning regimens in mud? Is basically the platform is fludarabine cyclophosphamide. And there are three, I will be coming to the details a little later, but there are three components which need attention: the dose of cyclophosphamide, whether 50 milligram per kilogram or 100 milligram per kilogram, a small dose or a higher dose, the total dose of the total body irradiation load 2 or 3 gray, and the dose and the brand of ATG, whether horse ATG or rabbit ATG thymoglobulin or rabbit ATG Fresenius. So how do we resolve these issues? So the conditioning, the first conditioning regimen is a standard of cyclophosphamide, fludarabine, and rabbit ATG with a small dose of TBI. And a GVHD post-transplant prophylaxis with cyclosporin, methotrexate, and 1 dose of rituximab to prevent the post-transplant lymphoproliferative disorders. An alternative is a CAMPAT-based conditioning regimen. In India, I'm not sure if people are using a CAMPAT. Most people would use this protocol. But when you use CAMPAT, you replace the ATG and the TBI. So it's basically cyclophosphamide, fludarabine, and the CAMPAT, and a post-transplant cyclosporin A. So the ATG or alemtuzumab, which is basically CAMPAT, are crucial in reducing the risk of chronic GVHD. This is important to remember. And when we use alemtuzumab, that is CAMPAT, the TBI may be omitted, but a mixed chimerism is likely to occur, to follow actually. So I was saying about the ATG source, and this data very clearly shows both in the matched sibling donor for both acute GVHD and chronic GVHD that rabbit ATG has an advantage, significant advantage over horse ATG. And so also for a mud transplant, a rabbit ATG has an advantage in acute GVHD over a horse ATG. So rabbit ATG is obviously preferred. And the same thing I have talked here on the overall survival, that the rabbit ATG has an advantage over the horse ATG in a mud transplant. So in a mud transplant, one will always prefer to use a rabbit ATG. So I was talking, the second issue was on the dose of cyclophosphamide. And this data published in Lancet Hematology in 2015 have shown that the graft failure and the overall survival are equivalent if you use cyclophosphamide 50 and 100. This is graft failure, the curves are similar, and this is for overall survival. So obviously most centers have moved to 50 milligrams per kilogram, which will have less toxicity and a little bearing on the outcome of the transplant. So conclusions are that for young patients, an upfront mud the data shows is comparable to matched sibling donor, and it is superior to first-line IST when you compare it head-to-head, and also superior when it is given upfront rather than if IST fails and then you give it. So that's why it has slipped up to to a place after in patients less than 20 years, in young patients, in the absence of an MSD matched sibling donor, a mud transplant has slipped up as the first option, equivalent to Hsct. So it may be proposed as the first-line treatment in young patients where there is no matched sibling donor. For all other patients, it is still continues to be a second-line treatment. And as I said, the most common conditioning regimen is flu-cy ATG low-dose TBI. An alternative is alemtuzumab with flu-cy, and GVHD prophylaxis is cyclosporin methotrexate, 1 dose of rituximab, and ATG given prior to transplant. But yet, a GVHD control is still suboptimal. And this is an area where science has to come in, and there is a further improvement which is needed. So third part is the haplotransplants. And it is, for a country like India, it may be a breakthrough in the management of severe aplastic anemia because of the ready availability of haplodonors and reducing treatment delays and allowing repeated access in case of graft failure. It's very difficult to get blood donors because of the restricted registries. But the main limiting factor has been an unacceptable rates of graft versus host disease and rejections. And though the current platforms are encouraging, but yet patients in general will exhibit a slow immune recovery and are prone to infectious complications. So this is the first data which was published on haplo from Dizern's group. They looked at 16 consecutive patients who did not have a matched sibling donor. And this is the Baltimore group. Dizern is from the Baltimore. And they used, for GVHD prophylaxis, PTCI, a post-transplant cyclophosphamide, at a standard dose of 50 milligram per kilogram per day on day 3 and 4. And they found good data. The median time to neutrophil recovery was 19 days, to red cell 25, platelet 27.5. And graft failure was not seen in any of the patients. This was what was the most important part of the data. And all patients became transfusion independent without any evidence of clonality. And only 2 patients had grade 1 or 2 skin-only acute GVHD, and 2 had mild chronic GVHD. So this was a very promising data. So what is the Baltimore protocol? The Baltimore protocol is a combination of fludarabine, cyclophosphamide with ATG, preceding ATG, a small dose of TBI, 2 centigrade, a transplant, a post-transplant 2 doses of cyclophosphamide, and then cyclosporin and mycophenolate. And this is the protocol which has actually become the most popular for haplotransplants, including in the PTCI, including in aplastic anemia. The platform for the conditioning being flu-cy ATG TBI. And this is a very, very nice study which has been published by the Baltimore group recently in 2020, where they have treated treatment naive 17 patients and relapsed refractory 20 patients with the Baltimore protocol for haplotransplants with a median follow-up of 32 months. The data is interesting. The median time to neutrophil recovery is 17 days. Primary graft failure was seen in 4 patients, these green dots. But what they did is that in the next 10 patients, another 10 patients, they gave 4 centigrade or 4 gray radiation. And they found that there was no primary graft failure. So they've actually switched to a 4 gray radiation. The grade 2 to 4 acute GVHD was only 11%, and chronic GVHD at 2 years was 8%. And they compared this result in another 10 severe aplastic anemia patients who received an identical regimen with PTCI but were matched donor transplant. They found similar results. So this is actually a very turning point data. And in fact, the papers, it's one of their abstracts which was presented earlier in ASH, I think, said the path to cure. Because if you see in the relapsed refractory patients, there is 100% probability of survival. And a graft versus host disease free survival is again very high at 36 months, being 84%. So it seems that a non-myeloablative, the Baltimore protocol in treatment of naive severe aplastic haplo-BMT, in treatment of naive severe aplastic anemia could lead to a paradigm shift. And essentially all patients, because if you don't get mud donors, they could proceed quickly to a safe and curative BMT. Then there is a Chinese protocol. A lot of haplo data comes from China. Aplastic anemia is more common in China, and they probably have got a lot of, they've got, this, in terms of the patient material, there's a lot of patient material there and clearances for doing haplotransplants. So they've done conditioning with BU, Psi, ATG, GVHD prophylaxis is methotrexate, MMF, and cyclosporin. And their stem cell source is a GCSF mobilized bone marrow combined with GCSF mobilized peripheral blood. So they've used BU-based, BU, Psi, ATG. And this is some of the data, the Chinese data, where they have done upfront transplant. And they find it to be comparable to the matched related donor transplants in terms of 3-year overall survival and 3-year freedom from failure survival. It's comparable. This is data from the registries. And then there's another Chinese paper, I'm just highlighting these two papers, where they've again looked at data in adults and children. Again, the registry data records of 113 severe aplastic anemia adults from 2 centers who received immunosuppressive therapy or haplo-Hsct within 6 months. So they've used it actually upfront. And they found an 8-year overall survival to be similar and a freedom from failure survival to be statistically significantly higher, obviously, in the haplo group. And the same kind of data for children below 17 years of age, comparing immunosuppressive therapy to haplo, where there is comparable 10-year years overall survival and a much higher freedom from failure survival. And then there is this meta-analysis, which again shows the survival curves of haplotransplants to be similar to intensive immunosuppressive therapy. Again, a Chinese data. And there is another protocol which has come up for haplos, which is non-TBI based. It is fludarabine, cyclophosphamide, ATG, busulfan. Again, PTCI, post-transplant cyclophosphamide, cyclosporin, MMF as GVHD prophylaxis, especially in centers if there is no TBI. And I wanted to just conclude out of all this data is that haplo achieves outcomes which are comparable to those of HLA identical sibling Hsct for severe aplastic anemia in young adults. And it may be actually the haplotransplants can be considered as an option for refractory severe aplastic anemia patients without a matched sibling donor. So if you have patients who don't have a matched sibling donor, you can consider it as an option for these patients, especially if you can't get a mud donor. But upfront haplo as an alternative for patients younger than 20 years with severe aplastic anemia, for whom no matched sibling donor is available, is questionable. It's not come up as a frontline therapy in the absence as an alternative for a matched sibling donor transplant. But it may evolve in future. There's much more data needed to it. But for refractory patients without a matched sibling donor, it can be an alternative, especially in those where you want a quick transplant, where there are no mud donors. It's a cheaper option to mud transplant also. So finally, about cord blood, just touching upon it. You know, it's not very popular in our country because of, you know, the earlier data showing high rejection rates and showing high graft failure rates. But it's kind of quite popular in the Europe. And this is the data from Dr. Latour, published in Blood, which is actually again a hallmark paper. It's a nationwide phase 2 studies where unrelated cord blood transplantation was done in these idiopathic refractory severe aplastic anemia patients. The study was in 26 patients. Eligibility was 1 or 2 unrelated cord blood units containing separately or together at least more than 4 into 10 to the power 7 frozen nucleated cells per kilogram, and not more than 2 mismatches, 2 in 6 mismatches between each cord blood unit and the patient. And the cord blood unit selection also required it to be negative for donor-specific anti-HLA antibodies. The APCORD, it's called aplastic anemia cord blood conditioning, was flu-cy ATG, TBI, 2 gray. And they've shown very nicely, the paper has looked at immune reconstitution, which may take anything from 12 months to 18 months, a good immune reconstitution, especially for the lymphocytes. But what is important is that their estimated 1-year overall survival was as high as 88.5% and 2-year of 84% using unrelated cord blood. Similarly, if you look at, this is again a report from EuroCord, Cord Blood Committee and Severe Aplastic Anemia Working Party of the European Society for Blood and Marrow Transplantation. And they've looked at the long-term outcomes of the cord blood transplantation. This is from HLA identical sibling. And they said 117 patients with either an inherited or acquired bone marrow failure syndrome who received cord blood from a related HLA identical donor. And 97 of these patients had inherited bone marrow failure syndrome and 20 had acquired. The 100-day acute GVHD was 15.2% and the chronic GVHD at 7 years was 14.5%. But the overall survival at 7 years was 87% for inherited and 81% for acquired. So it seems that cord blood transplantation can be considered as a second-line treatment for young patients who again do not have an HLA matched either related or unrelated donor and have failed a first Hsct course, with a conditioning with flu-cy ATG TBI and GVHD prophylaxis with cyclosporin, MMF, and rituximab. So what are the challenges? I'm sure all of you are aware of it in aplastic anemia, especially in India, is the occurrence of multi-drug resistant infections even prior to the transplant. Graft failures because of multiple transfusions, graft versus host disease, and a large part of it comes from a long delay between diagnosis and transplant because of financial constraints and arranging blood and platelets, donor support. This is a case which I want to end with, which highlights the kind of aplastic transplants we deal with. This is a young male, 13 years old, referred from BHU Varanasi to us, who did not have an inherited bone marrow failure syndrome as tested by us. Both no pathogenic mutations and chromosomal breakage test was negative with severe aplastic anemia. Did not have initially finances, started on cyclosporin, Minabol, arranged a little more finances, switched to ATG, Revolate, cyclosporin, failed to respond. Went on and developed a GI sepsis, and the ultrasound showed dilated small bowel loops with a questionable obstruction at the ileocecal junction, query tuberculosis. So he had to go through laparotomy with ileostomy, and the segment was resected off, the terminal ileum. However, it did not show any TB, but it showed a necrosis. And he was in ICU with this ileostomy for 25 days on noradrenaline support. Recovered, discharged, comes back with a fungal pneumonia and treated with voriconazole. By the time he gets financial assistance from the government for a transplant and is found to have a 10/10 matched sibling donor. So he's actually quite lucky. 1 year after the diagnosis, he gets finances for a transplant when we are able to find a matched sibling donor. He goes through flu-cy ATG conditioning, and we find that on day -6, he has high fever with chills and a murmur, a pansystolic murmur, which was maximum in the tricuspid area. And surprisingly, his colostomy site remains to be healthy. And on echo, we find that he has a vegetation in the tricuspid leaflet. And he thus was diagnosed with bacterial endocarditis, started on antibiotics, continues to have fever, kept alive with granulocyte transfusions. He's given repeated granulocyte transfusions. ATG had to be curtailed in him. We could only give him 2 days of ATG because of the sepsis. But we kept him alive with granulocyte transfusions, high-level antibiotics for bacterial endocarditis. He engrafts, neutrophil engraftment on day 14, platelet on day 17. And he developed cyclosporin-induced hypertension. This is part and parcel of the whole transplant game. Managed with 3 oral antihypertensives, finally discharged. And he continues to be well. And now he has been sent to the pediatric gastrosurgery, the pediatric surgical super specialties for closure of his ileostomy. So these are the kind of transplant patients we deal with. We often have to individualize protocols with them. We have to give them granulocyte transfusions. So it's a difficult ballgame. And the take-home messages, as I said, are anyone less than 40 years, the choice is a matched sibling donor transplant with conditioning with flu-cy with or without ATG, prophylaxis with methotrexate, cyclophosphamide, stem cell source in India, peripheral blood, though there is a need for better GVHD prophylaxis. Age less than 20 years, no matched sibling donor, consider an upfront MUD. All others, which means more than 20 years, you have to first consider an immunosuppressive therapy and then a MUD. And as I said, MUD conditioning, it's a must to have ATG low dose TBI. If you have to do away with ATG low dose TBI, then you have to give alemtuzumab. GVHD prophylaxis is cyclosporin, methotrexate, rituximab. Again, better protocols are needed for GVHD control. In a haplo-Hsct, it can be considered as an option for refractory severe aplastic anemia patients without a matched sibling donor. The Baltimore protocol, that is PTCI, is currently the most accepted. And cord blood transplantation can now be considered as a second-line treatment for young patients who have failed a first-line immunosuppressive therapy and lack an HLA-matched or mismatched related or unrelated donor. So thank you very much with these colors of Holi, and a belated happy Holi to everyone. Thank you.
Thank you so much, Professor Sonia Nityanand, for that lovely talk. Beautifully classified, beautifully presented. Even a non-transplanter can understand what you have delivered. Thank you so much. We will be going to the Q&A session, but just before that, we'll give you a break for 2 minutes and we will answer the quiz that we had put to the PG students. So the Sunday quiz that was put to you, you were shown a picture. There's a question mark on that picture, and you were asked to guess what that question mark means and forward the reply. This was the picture. So what do you see over here? This is a person who has got a hemoglobin AA, that means he's a normal person, and that is his normal sperm count. You've got a sickler, homozygous, hemoglobin SS. As you can see that he has got large amount of sickle cells, and sickle cell disease itself produces decrease in the platelet count. So there is this sperm count is shown to be low. And then you are asked this question that sickle cell disease plus something leads to decrease in the sickle cell, but also decrease in the sperm count. And there was a little bit of picture put over here. Various replies came. Some of you didn't exactly look at this picture at all, I think. And some of you felt that the answer cannot be simple, so you went into very complex replies. But the answer was very, very simple. And the answer was this picture that is shown to you over here. And that was simple, hydroxyurea, nothing else. So when you give hydroxyurea to a sickle cell patient, which you invariably give, because that's the most widely available anti-sickling agents that you have at your disposal, it does lead very effectively, decrease the sickling, but at the same time it produces further oligozoospermia. So this is what the answer was. This is some of the cartoons showing you exactly the data from the published literature. What you see over here is the total sperm count, millions per ejaculate, before starting hydroxyurea and after 6 months of starting hydroxyurea. You can see a significant drop in the sperm count. There's another study showing the same thing. The total sperm count, millions per ejaculate over here, before starting hydroxyurea, and this is 6 months after hydroxyurea, and this is the median. The red line is the median normal sperm count as per WHO. This is a study showing testicular weight on day 0, that is before starting hydroxyurea. The red is the control and the gray is patients on hydroxyurea. So in control, obviously the testicular volume remains the same, weight remains the same, and the weight decreases after 4 weeks and after 8 weeks when you're giving hydroxyurea. And this is a testicular biopsy before hydroxyurea therapy and after hydroxyurea therapy. The ST stands for the seminiferous tubules, and the SC stands for the Sertoli cells. As you can see, after hydroxyurea therapy, there's an atrophy of the seminiferous tubules. Sertoli cells remain intact, and there's a cellular debris. So the correct answer was hydroxyurea. A lot of people answered very quickly, I would say. From 11:42 to 11:46, within 4 minutes, we got various people answering correctly. Of course, a lot of incorrect answer. But there were a total of 8 correct answers, of which these are the 7 over here. 2nd, 3rd, 4th, 5th, 6th, 7th, 8th in the list, but in a very short span of 4 minutes. Dr. David V, Dr. Sanjeevan Sharma, Dr. Anand Prakash, Dr. Yoga Lakshmi, Dr. Yetendra Parashar, Dr. Andri Kurniawan, and Dr. Sumit Milk. You all gave correct answers, but the fastest finger fast So you all gave from 11:42 onwards. So the fastest finger fast at 11:41 a.m. was Dr. M. Gopinathan. Dr. M. Gopinathan, DM Clinical Hematology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. So congratulations, Dr. Gopinathan, and we will forward your prize to you. Fantastic speed, and you are just one of the 8 out of about 45 people who tried to answer. Congratulations to you, and thank you. So with that, we go to the question answer session. We have a lot of questions in the question box also, and of course the faculty is over here. I'll just begin with the question box. There are a couple of questions which are asking you whether with the success of Eltrambo-PAG based medical treatment, immunosuppression plus Eltrambo-PAG, does your algorithm change? There are 3 people asking that question. I put that together.
Okay, so I knew this question would come, but as of today, the algorithm does not change, and the addition of Eltrambo-PAG, no doubt, has produced unprecedented results. But still, one must understand that transplant is a curative option, and we do not still have enough data on Eltrambo-PAG for the evolution of clones, for clonal evolution, and the long-term effect of Eltrambo-PAG. So as of now, the algorithm does not change, except that the medical therapy is more profound with the addition of Eltrambo-PAG.
Thank you. Colonel Sanjeevan Shah.
Sir, thank you very much. Am I audible?
You're audible.
Ma'am, firstly, a fantastic talk on a Sunday. In fact, you went so meticulously into each and every aspect of the transplant. It was, pleasure revising the entire Hsct aplastic anemia. So I think it's, as you had pointed out, more of a discussion point. Most of these algorithms, rather than just a yes/no answer or a one-liner answer, most of these algorithms are based on severe aplastic anemias. Now, a significant number are the people who are non-severe aplastic anemias, in the sense that definition-wise, their ANC is not below 500, but they are nevertheless transfusion dependent, people who do require RBCs and platelet transfusion, but they don't have. So definition-wise, they are not severe aplastic anemias. So say in a young person, 40 years or 35 years, even with an availability of a matched sibling donor available, but the person is not severe aplastic anemia, what is usually your approach? Do you proceed to transplant? And as part 2 of the same question is, supposing it was a severe aplastic anemia and he did not have a sibling donor, so as per that algorithm, we went ahead and did a ATG cyclosporin with or without Eltrambo-PAG. And with that, within 4 months to 5 months, we did not get a complete response, but he got converted into a non-severe aplastic anemia. So in this case, now would you advise him a MUD or a alternative donor transplant?
Okay, thank you, Dr. Sharma. So it's quite clear that you have to, as I said, and you also have reiterated, that you have to balance the benefits versus the ill effects. It's looking at what is better at that point of time. So if it's answering the first part of your question, if it's a non-severe aplastic anemia, even if there is a matched sibling donor and the patient has a non-severe aplastic anemia, it would be, because see, aplastic anemia and any allogenic transplant will have complications, will have long-term side effects, which are the worst being mortality. Then you have acute graft-versus-host disease, you have chronic graft-versus-host disease. So it's worthwhile in a young patient, non-severe aplastic anemia, even if there is a MSD, keep the matched sibling donor at the back of your mind and try the medical treatment. The medical treatment now is quite lucrative. You can even give a combination of cyclosporin and Eltrambo-PAG to the patient. And if he responds and becomes, I think your main concern is that he's needing transfusions. If he becomes transfusion independent, you can even add ATG if he's transfusion independent. There's no really need to go to a transplant, and he's not infected. There is no urgency for, treating the aplastic component of his disease. Coming to the second part of your question is that after 4 months of immunosuppressive therapy of medical treatment, he does not respond completely, which is usually seen. You see, most of these patients will not have a complete response. It's a partial hematological recovery, but he's able to lead a day-to-day normal life, and he's transfusion-free. There is no point in subjecting him to another second treatment. So a lot of this actually comes with experience, with your feel of the patient and the needs of a patient. On the other hand, after 4 months, there's a partial response. Patient is having recurrent infections, very high transfusion load, and you're really not able to make out whether you will be able to keep this patient alive for another 4 months down the line. Then you start thinking of a transplant.
Thank you, ma'am.
Thank you, Sanjeevan. One question from the audience. Dr. Lily Wong wants to know, would reduced conditioning transplant be feasible for older patients in the age group 50 to 70?
Yeah, that's a good question. And I actually began by saying that, you know, a lot of treatment in hematology has moved from age, from chronological age to biological age, which is determined by the performance status, comorbidities, and there is no magic about cutoff of ages, you know, 40 years, 50 years, 60 years. So, I mean, I myself have done transplants in patients who are 50, up to 55 years of age, who do not have comorbidities, who are in a very good performance status, and you have a low intensity, you have a non-myeloablative conditioning regimen. So age in terms of chronological age is not important. The biological, the biology of the patient, the comorbidities, the performance status of the patient is more important. And you can, I think if the patient is good and does not have comorbidities, you can safely do allogeneic transplants up to 55 years of age, very safely, even in a country like India. You pushed in the graft will be taken up, the patient will be then free of infections once the engraftment occurs. So it's a possibility, very good possibility.
Thank you, Dr. Samir.
Good morning, ma'am.
Good morning.
Just to remind you, in the year 1999, when you did your first transplant for aplastic anemia, I was your registrar.
Yes.
All right. So my question is related to the previous question, and also Dr. One from the audience, where they've asked what is the lowest conditioning, or the shortest conditioning regimen that you have used in aplastic anemia. And I just wanted to share that the smallest conditioning regimen that I have used was 3 days of fludarabine and a single fraction of TBI. That's just 4 days, and a PBSC. And this I have used in 4 patients, and all of them actually did well. 2 of these were actually, they rejected their graft after a flu-Cy ATG conditioner and a marrow harvest. So I just wanted to know, it looks like an alarmingly, simple regimen, but it does work well. So I think in patients where, these infected patients where you need to put in the graft quickly and you need quick engraftment, I think something like this might be a good regimen. So I just wanted to know your experience, whether you've used any really short conditionings.
Yeah. Thank you, Samir. Thank you for bringing back old memories of where we started. I always miss you for that. And second, this is a wonderful suggestion. And that's why I said this, we have in the panel, very eminent bone marrow transplanters, and you are one of them. And the shortest regimen that I have used, I have not been so, I have not been as, one should say, innovative as you. The shortest regimen that I've used is fludarabine and cyclophosphamide, 6 days and 2 days overlap with cyclophosphamide without the ATG, and then pushed in the graft, the conventional flu-Cy, which, CMC Vellore has published also. So what you have said seems, and you have, data on it, I feel it's excellent, and you should publish it so that everyone else is benefited. And in India, this publication, this data would be very, very important, because, the whole idea in aplastic transplants in India is to push in the graft as quickly as possible. Prepare the patient and push in the graft so that after engraftment, it's a big sigh of relief to have engraftment in these patients, so that you stop this these sleepless nights of these patients getting all kinds of infections once neutrophil engraftment happens. So do publish that data, and share with us.
Thank you.
Thank you so much.
Thank you, Samir. Another question from audience. A patient of aplastic anemia is positive for parvovirus. How do you handle?
I think that's a simple, you can give intravenous immunoglobulins, IVIG for parvovirus. And it's important that it's important to look for all kind of infections in these patients. And some patients, I have this experience where the aplasia was reverted with the treatment of the parvovirus, but in some patients, it's an established aplasia.
Thank you. Dr. Sandeep.
Yeah, it was an excellent presentation, madam, and very meticulous presentation. And I had two questions. Whether do you use granulocytic transfusion as a standard of care, or it was used only for this particular patient?
Okay, thank you. So I think you're talking of granulocyte transfusions, no?
Yeah.
Yeah. So we use routinely granulocyte transfusions in our patients. Of course, there are certain indications, which is a life-threatening sepsis. And, it's our observation is at least 50-60% of these patients, which we published also, that 50-60% of these patients harbor multi-drug resistant organisms even before they're taken up for the transplant. And often we think that when they get back an infection in the post-transplant period, when they are ablated and they are on immunosuppressive therapy, they would get it by MDROs. So we don't wait very long. The moment we feel it's a life-threatening sepsis, we intervene and give granulocyte transfusion. So it was not only for this patient, it's a standard of care. And in fact, what I published also shows, with Akanksha, who's working with you now, we have shown that if you give it early, rather than before the sepsis goes into an irreversible stage, it has a much better survival effect and mortality than if you give it late, granulocyte transfusions within 7 days of a severe sepsis.
And my second question is for alternate transplant like MOD and Haplo. If there is no GVHD grade 2, 3, 4, then when do you stop cyclosporine or tacrolimus? Because sometimes you stop them and then you develop GVHD. Within few weeks, you have a severe GVHD. So when do you stop?
I think,
actually?
Dr. Shah, there is a minimum period for which, like what you said is very pertinent, that you give it for at least I would give it, because these patients are multiply transfused and they're not like Western patients. I would give it for at least a year. I'm a little more conservative.
Yeah, because sometimes patient is not having anything and we stop sometimes early and then
there is a flare.
Yeah. Thank you very much.
Thank you.
Thank you, Sandeep. Dr. Rasmi.
Ma'am, and good afternoon, everybody else. Ma'am, I have two questions. First is with regard to a patient who has infections prior to transplant. So basically, the patient presented to us in 2021 had a severe aplastic anemia due to COVID and everything. Patient was lost for further follow-up, has taken transfusions near his home. And when he came back now, he is actually hepatitis B positive. And this is a new infection. It was not there when we first saw him. So we worked him up. It looks like a significant infection. He has a viral load of just around 100,000 copies. We did an HLA. He doesn't have a full match among any of his siblings. There's only haplo match. So in this particular situation, he's very transfusion dependent. In fact, a little bit platelet refractory because of multiple transfusions that were not leukodepleted and irradiated. So in this particular situation where he is quite transfusion dependent, we don't have a full match and he has active hepatitis B. What is an ideal treatment scenario for him? And he's a young adult. So, should we go for, immunosuppressive therapy versus the only option for transplant for him is a haploidentical transplant, specifically in the setting of this active hepatitis B?
So this is not a very good situation, multiply transfused active hepatitis B infection. So first thing, as quickly as possible, and I'm sure you must have done it, you must put him on antiviral therapy.
Yes.
And try to bring down the hepatitis load. Has he, whatever it is, B or C, whatever infection he has, the load, the viral load has to be brought down. Once you bring down the viral load, again, you have to consider, for both for immunosuppressive therapy and for transplant, the active replicative hepatitis B infection is an adverse factor in him. So it will be for both. But then you look at other factors, if he's needing repeated transfusions, he's had other bacterial fungal infections, you have to you have to think again, individualize whether you can give him immunosuppressive therapy and wait for another 4 months, or you are in a hurry that he recovers his hematopoietic functions to some extent by doing a transplant, because the active replicative hepatitis B infection will be an adverse feature for both immunosuppressive therapy and for transplant. I know one always thinks of transplant as a worse situation, but in truth, both will be adverse things for him. So the first thing would be to give antiviral therapy and bring down the load of the virus as quickly as possible. And your gastro team needs to get involved.
Yes, ma'am. Yeah. And do we have to hit like a 0 viral copy? I mean, any target that we need to look at, or just a
so these people
reduction?
normally guide us, and what they tell us beyond this, I don't exactly know the cutoff limit, but they tell us, we've done it previously, that below a certain level, you can go ahead and give immunosuppression.
Immunosuppression. Okay, ma'am. Yeah. The second question was, ma'am, in this particular patient, since it's a haplo and he's been heavily transfused elsewhere, there is, he has positive donor-specific antibodies against, both of the potential haplo donors. So, doing any sort of DSA reduction involves again further immunosuppression. So,
yeah. So now you're in a greater tricky situation. If there is a high titer of DSA, I think you should not, most centers are not that well experienced with haplo also. If I have to do a haplo, I think 10 times, because our center still has not reached a stage of doing, routine haplos. So you have to think 10 times before you do it. It might be better than to give
immunosuppressive therapy. Okay. Yeah. Thanks, ma'am.
If anyone has a difference of opinion from the panelists, please express it.
Okay. There are no other raised hand signs. If somebody comes up, meanwhile, I'll ask you some questions from the audience. Dr. Radhika wants to know, young acquired aplastic anemia initially responded to cyclosporin and altrambopag. After 1 year develops PNH clone. What is the type of transplant you would prefer, MSD, MUD, or haplo? What will be the conditioning, and whether the source will be bone marrow or peripheral?
So the algorithm will remain the same. He definitely now needs a transplant. And, in PNH, when you do transplants, I don't know if it's a PNH or it's a PNH clone post immunosuppressive therapy, he definitely needs a transplant. The ideal will be a matched sibling donor transplant. In the absence of a matched sibling donor, then you look for a MUD or you look for a haplo.
Thank you. Dr. Chepsi wants to know, which has been the lowest stable mixed chimerism in your patients with patient doing well? And what would be the trigger to react?
Okay. So, initially we did not do a quantitative chimerism. So I have a patient, I think must be again from the time of Dr. Sameer, who has still a stable mixed chimerism. And he actually had an E. coli pyomyositis during the transplant. He was our first patient with the granulocyte transfusions. And then at the end, he developed a mixed chimerism, which over years has been stable. So we have not reacted to it. And he is actually absolutely fine, married, has 2 children. So, I would say that a mixed chimerism has to be, especially when you are doing a non-myeloablative transplant, has to be looked at from those eyes as to how much you should pay attention to it. That would be my approach. I would at times just leave it and follow up the patient. If the mixed chimerism starts increasing, then I would think of intervening. Because this is quite common in these patients.
Dr. Anand Prakash wants to know, in a dropping donor chimerism, would you increase or decrease immunosuppression?
Yeah. So if there is, like, if, as I said, if you're following up and there is a decreasing chimerism, obviously the whole idea is that you want the patient to go towards more of the donor hematopoiesis rather than the recipient hematopoiesis. So you start decreasing the immunosuppression. That is one thing that has to be done, and at times that works.
The question from Dr. Chepsi, what is the practice in terms of time interval between rejection and the second transplant? Is there an importance of the interval?
Yeah. After rejection, the mortality is very high. A lot of these patients succumb. This is my experience. So the earlier that you do a second transplant, and you need to go, if it was a match-related donor transplant, the second transplant, it would be better to do either a MUD. In the absence of a MUD, either a haplo or an umbilical cord transplant. So it has to be done as quickly as possible. And this is where, you know, the problem in this country comes in, because to identify the unrelated donors through MUD registries is a tedious process. It's not very quick, but the take-home message is that it should be done as quickly as possible.
Thank you. Dr. Radhika wants to know your experience about artesunate for treating CMV in patients where Valgan is contraindicated due to renal failure.
I do not have hands-on experience, so I don't think I'm the right person to answer this. Maybe the other people, you know, like someone else may want to, Dr. Sharad Domadwar or Dr. Sandeep Shah or Dr. Alok may want to answer this, or Ashish. Anyone would like to take up this? I don't have the experience. I know theoretically you can use it, but I don't have a hands-on experience.
Sir, can I just take on this part, sir?
Please go ahead.
Yes, sir. So I think it's more of a theoretical thing. So because we had this discussion on CMV infections recently post transplant, and there again, it's a theoretical question, but it's mainly in the realms of case reports here and there. So it's really, I mean, individually, probably none of us would have a long experience on this thing. So whenever we are encountered with such a patient, I'm sure we'll end up using it.
Unfortunately, there's nobody from Tata here. In Mumbai Hematology Group meeting, Tata has presented their data at a couple of occasions and successful use. And I think they have good experience, but today we don't have a faculty from there. Okay. The next question is from Dr. Kareem, 17-year-old girl. PNH clone in the flyer, 46%. Patient has severe aplastic anemia. Patient does not have a donor for transplant. What will be the response to medical treatment, non-transplant treatment?
Okay, thank you. So ideally, the answer, the best would have been a transplant, you know, a MUD or you know, in such a situation, you can think of a haplo. But if there is no possibility of patient affording a MUD or a haplo, or if the center doesn't having the facility, then you have no option but to turn to the immunosuppressive therapy. And like with the 46% clone, the same immunosuppressive therapy, if you take a combination of the 3 drugs, I think there would be about a 60% chance of a response rate.
Dr. Radhika has another question. After a transplant failure, when you're doing second transplant, can you repeat ATG?
Yes, you can repeat the ATG.
Dr. Narendra wants to know, is booster of hepatitis B vaccine given after bone marrow transplantation?
Yeah, so there is now a defined vaccination program after bone marrow transplantation, allogenic bone marrow transplantation. And I would recommend all the young participants and the discussants who are on this panel also, that they should follow it's not just the hepatitis, but they should follow the vaccination program, which is now laid down for post-allogenic bone marrow transplantation.
Thank you. Dr. Karim has
should not forget that.
Dr. Karim has another question. After ATG therapy for aplastic anemia, at what time interval do you declare that the treatment has failed?
Yeah, so, in general, if you see ATG therapy, ATG should respond by 4 months and usually between 4 and 6 months. So after, in the West, the time period at which they will switch to a second treatment will be after 4 months, but no later than 6 months. In India, I have seen a few patients who have even responded at 8 months. But generally, the cutoff will be not after 6 months. You have to take a decision for an alternative therapy for patients who have not responded to ATG. So it's like 4 to 6 months.
Thank you. Dr. Nilesh Jain wants to know what is the significance of DLI in slipping chimerism?
Yeah. So falling chimerism, people have tried DLIs. I do not have a personal experience, but literature says that in a subset of patients, they can work if DLIs are given.
Thank you. Dr. Vinayak Chikodi wants to know, does increase in mast cells after bone marrow transplantation affect engraftment?
I do not have the knowledge for this. I have not read reports on it. Maybe someone, I would not be able to answer this question about mast cells and engraftment. I know about mesenchymal stem cells, but I'm not aware of mast cells. So maybe someone else in the panel may want to take up this question about mast cells and engraftment in aplastic.
Fair enough. Let them think about it till that time. Dr. Anand Prakash wants to know, can we avoid ATG in MST conditioning for severe aplastic anemia? Is the experience of the experts identical to the one in the paper published by CMC below?
Okay, so I can tell you my experience and maybe other people can tell their experience that I have done away after this publication, and in fact, even before an abstract was published, and then we are in dialogue with CMC Vellore faculty also. At least in the low-risk patients, you can easily do away with ATG, 1. 2, some patients on their own drive you to do away with ATG, where, as I told, that they have already a pressing need for a very quick transplant because you don't want to spend another 4 days or 3 days in giving ATG. You just want to push in the graft where every single day is important in keeping them alive. And so these are the 2 circumstances in which I have not given ATG, and I have found very good results, and especially in the low-risk patients.
Thank you. Dr. Krishna Ratnam wants to know, what is the algorithm for managing graft failure?
Yeah. So graft failure may be primary and graft failure may be secondary. I would like to highlight here that this is a challenge in aplastic anemia, that primary graft failure has a very high mortality. Primary graft failure means that by 1 month also you find that the neutrophils have not engrafted, and it has a very high mortality. These patients, it's very difficult to keep them alive. And I have tried, for primary graft failure, all of us have probably tried. We tried, especially now, Eltrumbo-Bank. And because this is supposed to produce a stimulation of hematopoietic stem cells, and sometimes it is able to drive the hematopoiesis. So that's one option. And second option is that obviously it's a second transplant, but primary graft failure has a very high mortality, and often you cannot do a second transplant. And third thing which people have tried, which I have also tried in one patient, is to give a boost of the hematopoietic stem cells which have been cryopreserved and stored, or which again have been obtained from the same donor. So these are the 3 things which can be tried in primary graft failure.
Dr. Krishnan Ratnam also wants to know, what is the ideal conditioning regimen for mud?
Yeah, I brought it out in my presentation, and you can go back to textbooks also. It's a combination of drugs which you use, but the philosophy behind a mud is that you have to prevent a graft versus host disease. So it's good to give a TBI, a small dose of TBI along with the flu-cy ATG, which I highlighted in my mud protocol, is to give a small dose of total body irradiation prior to the transplant. And if you want to do away with ATG and with TBI, then you use the Campac, alemtuzumab. And I don't think in India people are using alemtuzumab. Maybe at Dharamshala they might be using it, but I don't think most centers are using. So it's a TBI and ATG along with Flucide.
Thank you, Professor Sonia, for answering all these questions, and thanks for that lovely talk. And thanks to all the faculty present here for interacting. And we hand over the platform again to Mr. Ashutosh Shukla for vote of thanks.
Yes, sir. Thank you, Professor Dr. Sonia Nityanand, for such a wonderful presentation. It was exciting, enlightening, intriguing, interesting, and much more. I'm sure all the participants must have felt the same. Thanks to the chief guest, Dr. Alok Srivastava, sir, for sharing your wisdom with everyone. Thanks to our elite discussions for your active participation and making this webinar even more informative. Thanks to all the participants for sparing your valuable time this Sunday afternoon. At last, I'm indeed grateful to Dr. M.B. Agarwal, sir, for your phenomenal effort in conducting this series of webinars, which has a very, very high academic quotient. The kind of effort, sir, which you are putting in conducting these webinars is something which is absolutely unbelievable. Last but not the least, I'm thankful to Team Mice Ideas for flawless execution of this program. Thank you, everyone. Good day.
Thank you, Ashutosh, and good day to everybody.
Yeah, thank you, and bye to everyone.